I am Dr. Carina Blackmore. I'm the state epidemiologist for the Florida Department of Health, and my unit is responsible for morbidity surveillance after hurricanes. And the primary goal of the work that we do is to identify preventable infectious diseases or injuries in communities or shelters that then we can work with partners to respond to implementing disease intervention or putting out communication efforts. Historically, we have conducted most of these activities through manual surveillance in the disaster areas, but over time we have shifted a fair number of our processes and rely more on electronic reporting of data, realizing that hospitals, as soon as they get up and running with electricity, etc., they're so dependent on their electronic systems, and as soon as they use their electronic systems, we can get that electronic data feed. So we get these data in a variety of ways. Most hospitals and laboratories in Florida report positive laboratory results for reportable acute diseases electronically, routinely to the department. And this would include foodborne disease-causing organisms, Vibrio, carboxyhemoglobin results, and other issues that we would worry about right after a hurricane and would monitor for after a hurricane. We then rely a lot on our syndromic surveillance system. It's called the Electronic Surveillance System for Early Notification of Community-Based Epidemics, or in short, ESSENCE, Florida, to in real time monitor chief complaint data and discharge data from emergency rooms. In that same system, we have an electronic data feed from our poison information centers and are able to monitor poisoning data as well, primarily for carbon monoxide poisoning, but also food poisonings, bite and stings, and other types of calls that the poison centers are getting. We also have real-time access to vital statistics data that Ken talked about. In addition, we worked with the U.S. Department of Health and Human Services to get electronic access in real time to de-identify data from disaster medical assistance teams, or DMATs, who are activated into areas where you have a Cat 5 or a complete disruption of services to provide healthcare services to the public in those areas. So then we use the electronic surveillance data and complement that with manual community-based surveillance in shelters. And then staff also work with DMATs and other healthcare providers should there be public health concerns detected so that we can then respond to those. So the advantages that we see with our electronic surveillance approach are several. We believe they're more timely than the manual system was, where we get data feeds every 15 minutes instead of at the end of the day that we used to have when we were doing foot-based surveillance going to emergency rooms. The system is a lot less resource intensive, both for healthcare providers and for the public health system. We can work remotely to do a lot of this work, which is helpful when the resources on the ground are limited and the staff in the impacted areas are assisting with a multitude of response activities, including to surveillance. We can take on some of those routine monitoring of data remotely and have them then be focused on activities that cannot be done remotely. We produce daily reports on surveillance results and share these with the overarching Florida Emergency Management Team. And what we have found over time is that in Florida, carbon monoxide poisoning, as has been discussed previously, is definitely a recurring issue after storms in our state. We do see infectious disease issues as well. They're less of a concern, but we do have the occasional vibriosis case, and we have seen outbreaks periodically, not routinely, but periodically in shelters. But that said, the real-time access to data is very useful for rumor control, which is something that is rampant after storms. And we can then use the data to avoid diverting our limited resources towards these rumor control activities. That's all I have. Thank you for being here.